Uh, Dear Facebook Pure Urology viewers and the urologists across the world, warm welcome to you. Good evening and good morning, depending on your respected places. We are doing regularly this program predominantly related to the urology, surgical techniques, as well as the latest advances in urology. As you all know, the renal stone disease is the commonest urological problem you come across most of the countries, particularly in India. Today, our esteemed speaker is Dr. Khurshid Ghani, professor, who is practicing at the moment in USA, Michigan. If you have seen the flyer I have sent, I'm surprised to see the latest articles of 170 publications he has done. Most of them are focusing on common practical issues like the heat generated during the laser, irrigation systems, laser tip distance, etc. Not only that, he has written the latest papers on the future role of various lasers and RIRS in stone disease. Uh, I welcome Khurshid Ghani sir for this meeting. Hello sir, good morning. Thank you for accepting the invitation to present in this group of nearly 6,000 urologists, as well as the entire India urology will be watching you. Before we go hand over the program, I like to know a brief about your career. At an younger age, you have traveled from India to London, then to USA. To be honest, this is a great achievement, we feel, and all youngsters like to listen from you. Where is your birthplace, sir? I am surprised to know that you are from India today only. I am very happy for that. Where is your birthplace, sir, if you don't mind?
Thank you, Dr. Mohan, for the invitation to speak. I was born in Kerala, that's right. So, and my family are both my mom and my father are both from Kerala. I was born in India, and I spent my first few years of until the age of 4 in India, and then I moved to England. My father is a doctor, and he immigrated to the UK around in the 70s. As you know, there was a wave of immigration at that time.
So, who was your mentor who influenced your life to go into the depth, the urology career before you went into the RIRS? Who was your mentor in the initial period of life?
You know, when I started my training in surgery in Edinburgh, and at that time, the urologists who I were exposed to were David Tolley, who was an endourologist, Alan McNeil, who's a uro-oncologist, and that unit really introduced me to urology, and that inspired me to become a urologist. But I have to say, I didn't know I was going to become an endourologist until I did a research fellowship at St. George's Hospital in London. And there my mentors were Ken Anson, who is an eminent endourologist in London, and Dr. Uday Patel, who's a uroradiologist. And I worked with them for 2 years doing research projects. And they're the ones that really inspired me to get into stone disease. And then, I got onto the London training program, what's called the Specialist Registrar Training Program. And I did that for 6 years. And I met many inspirational surgeons during that program. But I think a formative time in terms of my stone disease training was at Guy's Hospital, where I spent 1 year working at the stone unit. And there really inspired me to get more into academic work and get more focused on pushing the limits and trying to discover the problems that we're facing right now.
At what stage of life you moved from London to USA?
So I think my move to the United States was twofold. I have my wife, her family live here in the US. And so there was some desire for us to at least spend a few years, seeing what it's like in the United States. And then at that time, the field was, very active and interested in robotic surgery. This was the early 2000s. And I was very fortunate to meet Dr. Mani Menon at the Henry Ford Hospital at Vedakudi Urology Institute when I was a trainee in London. And, I found him to be quite an inspirational figure. And so I ended up doing a 2-year fellowship with Dr. Menon in robotic surgery at Henry Ford Hospital. So I'm also a robotic surgeon, and I do robotic surgeries as well as RIRS, which I'm going to speak about today. But and so I moved to the United States for just really 2 years just to do a fellowship. But I was fortunate, lucky, and circumstance allowed me to stay on here.
And during during your practice, if you are doing good job in robotics and RIRS, how your patients will choose depending on your publications or depending on your communication skill? What is your experience in USA? How your patient choose you as you have lot volumes of numbers as well as in RIRS publications. How your routine work happens?
I'm a specialist endourologist, so all my work is in the upper urinary tract. So I'm focused really on kidney and the urethral disease. The bulk of my work is in kidney stone surgery, RIRS, PCNL, but I do robotic surgery for kidney disease, whether it's obstruction, small renal mass, or reconstruction. I did actually spend a couple of months of my fellowship with Dr. Menon doing some robotic techniques for stone disease. So occasionally I will do robotic surgery for complicated stone disease. But I think the goal for me is to make sure the patient gets the best care. And if it's complex robotic surgery or oncological surgery, I will refer my patients to my colleagues here who do that. So, but in the United States, as a practicing surgeon, most surgeons are free to do whatever they can and they're capable and competent of. But in the academic environment, we do try and subspecialize.
Oh, that's great. Before going to the introduction, I will ask a final question. Do you think that the RIRS is detecting upper tract TCC more often in your experience in last 10 years?
It's a good question. I do think we are going to enter a new era where upper tract TCC is going to be managed more and more minimally invasively, endourologically through ureteroscopy. I would say yes, access to flexible ureteroscopy is now predominant, so people are detecting disease. But I do think that with the capabilities of the laser and our ability to do surveillance, this has led to that increase. And I think in the United States, the other major shift that we've seen in the last 1 year is the introduction of mitomycin gel therapy into the kidney, which is also, I think, going to push forward the conservative management.
Yeah, the reason why I asked this question is most of the Indians who live healthy after 75, 80 years, unfortunately are getting the lower ureter or upper ureter TCC, and then by the time it is recognized it is invasive disease. A liberal application of flexible ureteroscopy may avoid some deaths in these patients. We can discuss later on. Now I will introduce officially to the audience. Already nearly 80 audience are online. I will share my screen to introduce you. After that, I will hand over the program. And once again, for all the pure urology focused on basic surgical techniques, the audience today, an esteemed speaker, fortunately accepted the invitation to speak on the dust. It is not the dust. He will explain that. Professor Khurshid Ghani, Michigan. He has a great career. I have gone through recently. Is faculty at University of Michigan. He leads endourology program at the Ann Arbor VA healthcare system. He has done surgery from Royal Infirmary of Edinburgh. He has done urological surgery from London Deanery. He was awarded a Master of Surgery thesis from the University of London for research on percutaneous renal stone surgery. He completed subspecialty training in endourology at Guy's Hospital, London, which is well-known hospital. He is the director of the Michigan Urological Surgery Improvement Collaborative Music. He is the course director of a national symposium on ureteroscopy. Today we are discussing about that. Developments in ureteroscopic stone treatment, which has gone away in the last decade because of the laser and the flexible ureteroscope. He has been focused on advancing a dusting technique for endoscopic stone surgery and has extramural funding to study holmium laser lithotripsy. He has received numerous prizes for his presentation and research from the American Urological Association, Endo-Urology Society, and the European Association of Urology, and has lectured and taught surgeons throughout the world. He is an assistant editor of the Journal of Urology and serves on the editorial boards of the British Journal of Urology International and Nature Review Urology. He has authored over 178 peer-reviewed publications. In fact, I have sent the link of the abstracts of these articles. Most of them are close to our regular doubts, like the energy, the dissipation of the energy, temperature, the outflow, water, measurement of the temperature, measurement of the intrarenal pressure, all the things are addressed. So many common things. He is the co-editor of a textbook, Endourology, a practical handbook. His research interests include novel technique of endoscopic and robotic surgery for renal stone disease, health services research, and surgery quality improvement. With this introduction, I hand over the program to Professor Khurshid Ghani. Thank you very much, sir. Over to you.
Thank you. Thank you, Dr. Mohan. And the slides are coming across okay?
Yes, sir.
Okay, thank you. So I appreciate the invitation to speak to the surgeons in your group, and I'm looking forward to any questions and discussion afterwards.
If you don't mind, I may interrupt appropriate time. I will try to avoid, but to make it interactive, I will take your permission and interrupt, please.
That would be wonderful. That would be absolutely wonderful. So I'm going to focus today, my focus is on high frequency ureteroscopic renal stone dusting. So it's ureteroscopic RIRS, and I'm really focusing on the kidney stone and not the urethral stone, because there are some differences in how we treat those stones in terms of strategy and laser settings. My disclosures: I am a consultant for multiple medical device companies, and some of those companies make lasers. And importantly, I do have a grant with Boston Scientific, along with my partner, Will Roberts, here at University of Michigan, where for the last few years, we've been studying some of the parameters and settings and aspects around laser lithotripsy in the lab. So what I'd like to talk to you about is really how I approach patients with renal stone and how I, approach a dusting technique. And our focus is really around surgery, but I think it's important to understand that it's the whole package, and it really begins from the moment that you see the patient with counseling and planning, and to the follow-up and the post-operative. So I will cover some brief points on that as well today. I got this line from Dr. Mahesh Desai, who was a visiting professor to our unit some years back. And I think, that is the fundamental principle of not doing any harm. So whenever I see the patient, as many of us see patients with kidney stones, and not all of the kidney stones are symptomatic, not all of the stones need treatment. And even the smallest stone sometimes does need treatment because of the symptoms and the suffering that the patient is having. So I do take a lot of effort to understand the complaints of the patient and what their priorities and what their goals and focus are in terms of treatment. When I plan a ureteroscopic treatment, my goal is to keep it very simple and to do the least amount possible in the quickest amount of time, in the most efficient time, and to make it as painless as possible for the patient. And I do think, as surgeons, we all understand that the urethral stent after surgery is one of the biggest morbidity aspects and complaints that our patients face. And I think the dusting technique will promise us more and more options of leaving patients stentless and decreasing the morbidity that they suffer from this operation. So when I do speak to patients and they have the appropriate stone parameters, I do speak about stent emission. In my practice, it's quite routine not to leave a stent after the surgery. I talk about the risks of what that might mean. In our unit, when we looked at cases who were stent omitted, we found that the risk of them coming back to the emergency department for pain or for some problem because they didn't have a stent was less than 0.5%. So we counsel them on that risk. I talk about residual fragments. I try to understand if they think that residual fragments less than 1 millimeter or 2 millimeter are acceptable to them. That might change my focus into maybe a hybrid strategy or a pure fragmentation and retrieval. And there are other aspects in their care in terms of prior sepsis and social factors that will determine decision-making in terms of stenting and techniques used and follow-up. But so for every patient, it's an individualized approach. And this statement comes from Dr. Pal Oster, who's an eminent endourologist in Europe, the PSA personalized stone approach. And I completely agree with that. So let's talk about the kidney stone, a simple kidney stone that sits there in the kidney in a patient. And when it comes to, and I know the three-dimensional volume is important, but many of us are just doing a maximal dimension size at the moment. And when I look at these stones, these are my criteria for when you can avoid a stent. And in my practice, most patients with a stone less than 1 centimeter, I can dust them and I can avoid a stent. But as the stone gets bigger, the chances of having stent emission are reduced. And definitely for larger stones that are greater than 2 centimeters, I will counsel them on a staged procedure. If I am doing a staged procedure, I do it upfront in advance, and I book the patient for 2 consecutive procedures 2 weeks apart, so that there's no confusion that the stone does require 2 trips to the hospital to get it treated. You have to bear in mind that in the United States, many of our operations are ambulatory procedures. In other words, patients are operated usually in a facility that's not at the hospital, but a standalone facility, and patients will go home that day itself from the recovery area. So these are all day case procedures. Nobody is spending the night in hospital after urethroskopy. That's extremely rare. I start all patients on an alpha blocker, a tamsulosin. They get a 30-day prescription and they start that 7 days before surgery. I got this from Dr. Clayman, who found that his ability to insert large urethral access sheaths was improved when using alpha blocker therapy. And I thought, well, this may help me to be more successful in getting a ureteroscopic insertion and facilitation and avoiding an access sheath during surgery. So all my patients get alpha blockers. They all go through a comprehensive educational program on what it means to have ureteroscopy. And that's really important because the asymptomatic stone, a patient with a 1 centimeter kidney stone that has no symptoms but has been picked up on imaging, and this is what we're seeing a lot in the modern day, imaging detected disease. These patients walk into the surgery with no symptoms, but they're going to leave the operation symptomatic. And it's really important for them to understand that. And as a result, we have a comprehensive program of education around the surgery. We have documentation and literature created for this, and it's freely available for anyone to use on our musicurology.com website, and the details are here. But we have a host of information for patients to counsel them. So now I'm going to move into the surgical aspects, and I want to go through 10 operative steps for strategy. So the first thing is the overall strategy. I spend a lot of time before the patient heads into the operating room with my resident and my nursing team, understanding what is our plan for treatment for this particular patient, what type of equipment are we going to use, and we have a board in the operating room where we will put everything that needs to be opened is opened, and everything that we might use during the case is available, sitting there, ready to be opened if needed. Because one of the things that, frustrates me is if I want some particular equipment and the nurses can't find it in the room, and then they have to go and find it in the, common area, and this is a waste of time. So I'm very focused on reducing any inefficiencies in the operating room. And this also sets everyone's strategy around what the plan is for the case. And remember, especially for us in the US, every equipment is a single use. It's a disposable equipment. Everything costs money. So our goal is to be careful and considerate in what we use. I communicate with the anesthesiologists around my anesthetic needs. Because these are all patients that are being done in an ambulatory facility. Mostly, a lot of patients are given LMAs, and I find that sometimes the LMA is not adequate for renal stone dusting, where I want some control of their ventilation. If it's a complicated case, I will definitely ask for paralysis and sometimes apnea. And this was a good paper on this subject by Dr. Trakcher's group some years ago. So I will communicate with the anesthesiologist. In general, I'll ask for endotracheal intubation for kidney stone dusting. And then I have to start with a strategy on how many guide wires I might want to use for the case. So if I'm not using an access sheath and I'm just using a flexible ureteroscope, I'll use one wire that is my working wire to get my scope into the kidney, and then I will remove that wire. If I am using an access sheath, I will use usually just one wire, because I use what's called a parallel design sheath. And in this type of sheath, the wire is on the outside of the sheath. And then when you remove the inner obturator, it flips that single wire onto the outside. And so you still have a working wire. But if I don't have a parallel design sheath, I will use two wires, because I do like to have a safety wire when I'm using an access sheath, because if I'm worried about access sheath injury, and I'd like to have a safety wire in case that happens. So how often do I use sheaths? Well, I have to say that, when I started the dusting technique many years ago, I was using maybe 20% of my cases are using access sheaths. I would now say that figure is close to 50%. And these are my criteria for using access sheaths. In a very simple schematic, it's when the stone is big, bad, or ugly. So if I think I'm going to spend more than 20 minutes in the kidney doing laser lithotripsy, I'm concerned about that operating room time in terms of intrarenal pressure. So I'll place a sheath to mitigate the intrarenal pressure in terms of allowing me to use higher flow rates and not be concerned about pressure changes. I also think in certain cases, the access sheath will improve our vision. And definitely if there's a risk of infection and hydronephrosis, I will use an access sheath for those reasons. And then if on CT planning, if the Hounsfield unit is high, I'm talking about 1400 and higher, and then I'm thinking that, I may have to do a hybrid technique, do a lot of dusting in the beginning and then do fragment retrieval at the end. And this is a video example of me using a Storz ureteroscope dusting a stone where I didn't have a sheath, and you can see I'm having issues with a little bit of vision. And also one of the aspects here is that this is a uric acid stone. And so stone composition may also have a factor in our decision making. If I have a non-stented patient, I will use small caliber access sheaths. If the patient is pre-stented and I want to place a sheath, that's when I'll use larger access sheaths. And if I don't use a sheath, which is happening 50% of the time, I will place a small 12 French red rubber soft catheter into the bladder for constant bladder decompression, because I think that, that will help promote a lower urinary tract pressure environment. So now I want to move on to scope selection. So we spoke about guide wires, we spoke about access sheaths. Now I want to speak about scope selection. So in general, my go-to scope is a small fiber optic flexible ureteroscope. In our unit, that's the Olympus scopes, and we use P6 or P7s. And that's because a lot of the time the stones are less than 1 centimeter, and I'm planning to do a stentless technique. So I want the smallest caliber ureteroscope to cause the least amount of ureteral trauma. And I want to do it in the quickest amount of time. And my philosophy is less is more. If the patient is pre-stented, I will use a digital ureteroscope. They are slightly larger caliber, but because the patient is pre-stented, in that scenario, I'll use those. And these days, I'm doing more and more wireless ureteroscopy, and the pre-stented patients are excellent to do wireless ureteroscopy. If the patient has a stone in a lower pole, and I think it's going to be a tough case, that's my criteria to use a single-use scope. There are many on the market, but we currently have LithoView scopes, and I found them quite durable and robust for this scenario. And then a couple of caveats around left-sided surgery and right-sided surgery. And my mnemonic for this is left is for LithoView. And so when I have a stone in the left lower pole, I will opt to choose the LithoView scope. If I have a stone in the right lower pole, I'll opt to choose an Olympus system. And that's because of working channel direction. So if you look here, the LithoView scopes and also the Karl Storz systems, the working channel of the laser fiber is coming out at 3 o'clock. In the Olympus scopes, the working channel that comes out at 9 o'clock. And these are events that happen by the manufacturers, not for any particular purpose. It's just the way that they've designed their scopes that the working channel has actually come out at that direction. And so this does afford us some unique advantages and disadvantages depending on the stone location. And you can imagine on the case on the right, if the laser fiber was on the left-hand side, if it was at 9 o'clock, it would be more likely to irritate and hit the infundibulum. and vice versa. So sometimes knowing which side your working channel is can strategically help you in difficult cases where it gets the laser fiber right onto the stone and not hitting the infundibular wall and causing bleeding. So we talk about scopes. I'd like to now speak about laser fiber selection. My go-to laser fiber is a 200 small core fiber. I have not opened a 365 core fiber in 2 years. I just don't use it. I don't even use that for semi-rigid urethoscopy. I think the 200 core fibers these days are very robust. Definitely for RIRS, they're versatile. They get you into the lower pole. And importantly, vision. It allows higher irrigation rates. And vision with dusting is an issue, and that's going to be an increasing issue with advanced lasers getting us better and better quality of dusting. And the other aspect of laser fibers is the one with the ball tip. And so a lot of my laser lithotripsy is done with the Moses system from Luminous, and with the Moses, all their 200 fibers have a ball tip. And I find it very helpful for inserting in a deflected scope in a lower pole. One thing to be aware about the ball tip is that, the ball tip does erode after some use. I think many of you will be aware about that. And so when I'm strategically working in the kidney and I have lower pole stone and upper pole stone, I'm going to work on my lower pole first because the ball tip there is intact. And later on, it may erode after laser lithotripsy. Moving on to irrigation, and I think this is a really hot topic now. What is your irrigation? What are your rates? And I think you all need to understand that they can be variable, and you'll all have to decide what actually is coming at the end of the scope. And what is coming at the end of a scope in an open system, such as you're seeing in the videos here, may be completely different to what is coming in a closed system in the upper urinary tract, based on the compliance of the urinary tract, based on the dilation of the ureter, based on so many other factors that we don't yet really know. But in general, for simple ureteroscopy, where I'm not doing laser lithotripsy, I do gravity drainage at 1 meter height. But when I'm doing laser lithotripsy and I'm dusting, the vision is impaired with gravity drainage, and I don't use intermittent boluses of hand irrigation. I will use constant higher flow irrigation. I use pressurized saline, so the 1 meter height of saline is pumped up to 150 millimeters of mercury, and that gives a flow rate of around 38 to 40 mLs per minute in an open system, as you can see here. But then I will modulate the irrigation through a valve. So through the valve here, there's a metal valve here, and I will tweak that. So I will increase or decrease the flow rate as I need during the case, but it's a constant rate. I think that the hand irrigation boluses that are intermittent may lead to higher spikes in intrarenal pressure than a constant rate. So I've refrained from using hand irrigation methods. The other thing about a system like this is it does allow me to aspirate urine, whether I want to send for urine culture or just to carefully clear the field at the start of the case. But at the end of the case, I use it to flush some of the fragments out of the calyces for clearance. So now let's talk to the initial steps of the setup. When I do RIRS for kidney stones, the first thing I do is I put the patient in Trendelenburg position. And that's a number one step for me. If the stone is in the renal pelvis, I try and push the stone out of the pelvis towards an upper pole or interpolar location. So with the patient in Trendelenburg, I then use the tip of my scope to nudge the stone gently away from the renal pelvis, as you can see here on fluoroscopy, into an upper pole location. Why? Because I want control. I don't want a laser lithotripsy in a renal pelvis if I can help it, because I don't want fragments shooting off into different calyces, and I don't want them, especially going into the lower pole. Sometimes it's not possible to push a stone that's too big into this pocket. So then I will debulk the stone in the renal pelvis as one entity, and then when it gets small enough, I'll then push it. And then the others. My second reason for this strategy is, no matter what laser you use, no matter what technique you use, you will end up with fragments. And then your next step is to break those down with a pop dusting, a pop corning technique. And if the stone is contained in a calyx, that is when you're going to get the best results for that. And we'll talk about that a little bit later. So I call this part of the procedure nudging the stone. We'll talk about laser settings. So this is the laser I most commonly use, 90% of the time. I do have access to thulium laser, and we can talk about some of those differences later on. But this is the pulse modulation system from Luminous, and it's Moses. And so the aspects that you can choose are different pulse durations, long and short. How much pulse energy are you putting? I tend to use pulse energies from 0.2 to 0.5 joules, and I will vary that according to the stone composition. Pulse frequency, I do use, have access to the Moses 2.0, and the frequency goes up to 120 hertz. And so I'll choose a frequency somewhere between 50 and 120 hertz, depending on the stone location and size in the kidney. In terms of the pulse modulation, this is what's called the Moses mode, and I'll speak a little bit about that later. And it's really important that we're conscious about how much power that we use. And what you're seeing on the panel right now is my sort of go-to setting. The setting on the left, 0.3 and 50, is my starting initial setting with renal stone dusting. It's a low power setting. It's 15 watts of energy. It's fairly safe, even if you're using gravity drainage irrigation. It's safe in terms of heat generation. And I'll show you some data on that shortly. But the setting on the right is definitely a high power setting. No doubt, 40 watts is high power. And that's my pot dusting setting. But I mitigate that by using higher flow rates for when I have that aspect of the procedure. But there are three things that you have to manage as you're doing laser lithotripsy, as you're tweaking all your settings, is how does the setting affect my fragmentation? How does the setting affect my retropulsion? And how does the setting affect my burn back? I can pot dust at 40 watts, but have terrible burn back on the laser fiber. And I can pot dust at 40 watts and have no burn back on the laser fiber. And burn back's really important, because if you get burn back, you're wasting time either cutting your fiber, stripping your fiber. And of course, the fiber, the efficiency at the tip is reduced, so you're not getting as good fragmentation. So managing your laser fiber tip is critical. So these are some examples of that initial phase. The stones here have all been pushed into an upper pole location, and I'm doing a contact laser lithotripsy strategy. I am brushing the stone. I am constantly interrogating and moving around, doing dancing, painting, chipping techniques. My goal is not to stay in the middle of the stone and fracture it. I want to shave the stone as one entity and see it get smaller and smaller as one cohesive unit. And that is the contact phase of laser lithotripsy. And the settings I use will be based on the laser that's available to me, whether I have a laser that has the short pulse or long pulse mode. If you have lasers that allow you to do that, long pulse is very good because it reduces retropulsion and is good for dusting from that perspective. But if you have pulse modulation, such as the far right, I use the Moses distance mode, as you can see here. And in that particular mode, I do feel that it melts the stone and ablates the stone with a dusting technique much, much better. So this is some work from our group in our lab, led by Ali Al-Duki, who was our fellow a couple of years ago. And what we did here is we lasered artificial stones in a very controlled environment. We used multiple modalities of short, long pulse, and then the two different Moses mode. They're called Moses contact and Moses distance. But we actually put the laser fiber in touching the stone itself, and just brushing the stone and moving along. And what we found is that the Moses distance mode, even though it's touching the stone, led to around 30% more fragmentation. And that was striking. There's been no mode discovered that increases fragmentation. And so this is the only mode in the Holmium system that has been shown both from our data at Michigan, but also by the Duke group and others in Montreal, that actually increases the amount of fragmentation. Now, if we move to actual what's happening at distance, this graph is critical, because what you'll see here is that being on the stone causes the most fragmentation. So that's why we want to touch the stone all the time. But if you're 1 millimeter away from the stone and you're using short pulse, that's a common mode that everyone's using, you'll see that you're getting much less fragmentation. We all are aware of that. But when you're using a Moses distance mode, you're increasing that amount of fragmentation. and by at least 100% at this point. And this is really important, because when we're doing a dusting technique, as you know, you're moving around, you're touching the stone, you're not touching the stone. How often are we actually more than 1 millimeter away? And work in our laboratory led by my colleague Will Roberts in an elegant study that's now in the J Endo showed that we are more than 1 millimeter away around 50% of the time. So if 50% of our operating time when we're doing laser lithotripsy is at 1 millimeter or 2 millimeter distance, I think it helps us to be using a mode that's optimized for that. And that mode is Moses distance. So when I use the Moses system, I use the Moses distance mode for kidney stone dusting, but not for urethral stone dusting. For urethral stone dusting, I use contact mode. Now, this is a case of a big calcium oxalate monohydrate kidney stone that I'm doing dusting with the Moses distance technique. And, you know, I start with 0.3 joules and 70 hertz. And then I increase my energy as the case goes on. I'm just showing you a combination here of touch and no touch. There is some, you can see some photothermal carbonization, some charring that occurs, and that's going to happen the more that the stone digs into the stone. But the more you can just stay off a little bit, you're going to get less of those sparks and flashes. But the key attribute that I want to show here is, look how beautiful that you can dust the stone here. Everything that has been ablated to this point is of no concern. It will irrigate with the fluid. And so that is the goal here at that initial contact phase, is to ablate the stone so it's vaporized. And then we move to the next phase where there's fragments in the calyx where we're doing popcorning, and you can use either lower power settings of 1 joule and 20 hertz or higher power settings of 0.5 and 80 hertz, which at Michigan many years ago, when we started studying this and doing the clinical techniques around it, we termed the phrase pop dusting. And we call it pop dusting because it's different to popcorning, because it's using much higher frequencies and it's using a moderate pulse energy. And so we do find that the moderate pulse energy of 0.5 joules and a higher frequency of 50, 60, 70, 80 hertz leads to the best results. We study this in the laboratory. So higher power, higher frequency, and importantly, doing the technique in a smaller cavity versus a larger cavity leads to the best results. And that's why we do pop dusting in calyces and not in the renal pelvis. And when it's working at the end, you can see that the renal pelvis is full of all the tiny, tiny stone fragments and debris, which floats and moves easily in the fluid. And these are the scenarios where you can say that this patient hopefully will have optimal clearance with no stones at the end. Just a few comments on the lower pole. So classically, I used to basket displace lower pole stones. I don't do that anymore. Only if the angle is very tight will I pick the stone up and basket displace into the upper pole. What I now do is do in situ lower pole lithotripsy if the angle is acceptable. If they're big stones or small stones, this is a case of a semi-live case I presented at the World Congress. And you can see here, I'm doing in situ lower pole lithotripsy with a big stone, and the high power systems cope with it very, very well. This is a case of me doing in situ lithotripsy for a much smaller stone. You can see my initial strategy is a contact strategy. I'm trying to touch the stone and I'm breaking it up sequentially into smaller and smaller pieces. I'm using a lower power setting, at 2.2, 0.3 at 120 hertz. And then the stone does crumble into smaller pieces. At that stage, I'm doing a pop dusting strategy and intermittent bursts with higher power. And then I keep doing that until I get sub-millimeter fragments. I use the tip of my laser fiber to determine the size. The laser fiber tip is around 0.2 to 0.3 millimeters. So I look at my laser fiber tip and I look at my fragments. And ideally, I want less than 0.5 millimeter, but less than 1 to less than 0.5 is what I'm aiming for at the end at this aspect of the technique. And in the lower pole at the end, I will then gently flush the fragments out of the calyx, try and clear the fragments at the end. And I think in the future, evacuation techniques will be more advanced. There will be more adjunctive procedures that allow us. And I also predict that in the future, we'll be able to constantly suck when we do laser lithotripsy. This will advance us in many aspects, whether it both comes to laser lithotripsy and intrarenal pressure mitigation. So some comments on total power that we're using during the case. This is work led by my colleague, Will Roberts, here in our lab, where we looked at the heat generated in a pig when we did laser lithotripsy. And this is at 40 watts of energy, so 0.5 joules at 80 hertz. And of course, if you have no irrigation, which is in red, you're going to hit dangerous temperatures. If you have medium levels of irrigation, which is around gravity drainage, you will have high levels of temperature if you laser constantly for a long time. So it's really important to keep your laser bursts short, 5 to 10 seconds, and let the heat dissipate. But of course, if you use higher flow irrigation and you can laser for many seconds, you won't hit dangerous thresholds of temperature. But we have to bear in mind this is all done in the laboratory and in the lab, and what we think is coming out of the scope in terms of the rate may be different from what's happening in the patient for other factors of compliance and other dynamics. But in general, if you're going to use high power settings, these are some strategies to mitigate heat generation. Do intermittent laser bursts, definitely use higher flow rates. Use a urethral access sheath. I mean, all my complicated stone cases, I do not do without an access sheath if I can help it. We do not use warm saline, we use room temperature saline, and there may be a role for chill saline in the future. And I think other measures of active suction in the future will help us here. So some final comments on stenting. At the end of my case, all patients get furosemide, for diuresis. They all get intravenous non-steroidal, such as a toradol for pain relief. And then, if they're a big stone that I've dusted, I use a silicone stent. In many patients, I try and avoid a stent, but if the ureter feels tight, I will place a stent on a string for 5 to 7 days that the patient pulls out. If I don't think the patient can cope with the string, what I call the stent IQ, then I won't leave a string. I do not do short duration stenting. I used to put patients with a string for 3 days, 2 days, and I found those patients had more pain. And so my minimum time for stenting is 5 days. And there is some data in the pig model that shows that the ureter is in spasm and not optimally dilated until the 4th or 5th day. So I think some of these patients can have problem. Of course, if the patient is pre-stented, this is a good criteria to leave them without a stent at the end of the case. So these are some aspects around stent emission. Definitely I don't use an access sheath. I use a small caliber scope. The procedure was atraumatic. And a good visual cue is seeing fragments, dust in the ureter as you're exiting, and also seeing dust and fragments in the bladder. And that's a good visual cue that this is a patient whose system will drain. And in many of those cases, I will leave no stent. All my patients get a specific post-operative regimen. They get intraoperative non-steroidal, they get post-operative non-steroidal, they all get alpha blockers. If they get a stent, they all get anticholinergic. It's not a case of maybe or maybe not. If you have a stent and you have no contraindications, they get an anticholinergic for the duration of the stent. And this is my own personal data. In the state of Michigan, we have the music group that collects our data and gives us feedback on our outcomes. And you can see here that I place a stent 21.7% of the time of my URS cases. And this is for all cases, both urethral and renal. And it tells you my imaging rate, my stone-free rate, and all the other aspects of treatment. In terms of follow-up, I do CT scans for complicated cases. If possible, they're low-dose CT at 6 to 8 weeks. This is an example of a lower pulse stone that I treated, and I got a CT scan to assess clearance. But I am conscious about radiation exposures. So in some patients, they'll only get an ultrasound or a KUB. Ultrasound is really done to rule out hydronephrosis. I think it's quite frustrating when it comes to stone size and quantity, and it can be misleading. So I'd just like to close, again, going back to the principles: listen to the patient, keep the surgery simple. always ask yourself, every strategy that you're doing, how much pain is it causing my patient? And we hear this all the time. Pain, they want minimal pain. And when I've done a dusting technique that's stentless, sometimes I'll speak to the patients a few days later to see how they're going. And those that report no symptoms, able to go to work with no difficulty, I feel great satisfaction that we managed to get that outcome for them. And if it doesn't work out in endourology, you can always place a stent and come back, and you can always live to fight another day. So, Dr. Mohan, I want to thank you for your invitation, and I'm happy to take your questions. Just one comment. We have a meeting, and you did say DUST. DUST stands for Development in Uroscopic Stone Treatment, and we will be running a virtual meeting this year, a worldwide virtual meeting on October the 30th. I'll give to your Facebook group. I hope many of your surgeons in India can attend that. It's a free meeting. We'll have many worldwide experts speaking about the latest developments in uroscopic stone treatment. Thank you.
Thank you. Thank you very much. That's an excellent talk, covering all the aspects of the flexible ureteroscopy. More than 200 audience are online. So if with your permission, I will close this screen and come back to the questions.
Please.
Yeah, I will have a quick fire so that people will be knowing much from a knowledge and academic interested person. Number one question: if you put a stent in all the cases and don't put the stent subsequently, is a good strategy to avoid complications. Ureter is dilated, large stone can be dealt, no fear of infection. 10th day you go back. First time you put the stent on a daycare for 5 to 10 minutes. Second time you discharge on the same day. Does it good for all the cases to avoid any injury to the ureter, which is disastrous?
So you're talking about the role of pre-stenting,
Yes.
Is that right? Okay. So we don't do pre-stenting here as a matter of strategy and routine. And I know it's quite popular in Europe and maybe in India as well. And I think, of course, there are some advantages of it. We know we have data here in the state of Michigan that pre-stented patients have, lower complications, easier facilitation of the procedure. So, but I won't do pre-stenting as a strategy. For the complicated stones, like you mentioned, a 2 centimeter stone, 3 centimeter stone, that are going to require 2 procedures. Since they're going to need 2 procedures, we will attempt the first procedure with an access sheath, but for a very short time in my schema, and then place a stent and bring them back. If, of course, we can't get access into the kidney, then that's it. It's set. If the ureter is too tight, we won't push the limits. I'll put a stent in and they will come back. So they're counseled on the need of that. But I do feel that you have that first visit, you might as well break as much stone as possible. Now, if they are an infected case, I agree with you. I would have to say that the more complicated patients who have large stone disease that are infected, I tend to do percutaneously. But in those who have contraindications, anticoagulant therapy, etc., if the infected cases, there may be an argument in those patients, absolutely, to place a stent and then bring them back.
Yeah. What size of the stone as of now you prefer for RIRS, and what size of the stone you slightly tend? It's a vague question. It depends on the location. It depends on the solitary kidney or normal kidneys. It depends on the access by the RIRS. If I say that you put a flexible scope in all the cases, do an RGP. If you can reach easily, do RIRS. Otherwise, you quickly convert it into PCNL. Can it be followed, or you will decide before only to the patient?
I tend to decide before in advance. So the only times are those who are consented for endoscopic combined approaches where I still think the lower pole complex, the large lower pole stone, is still problematic for RIRS, So those are the ones that I gravitate towards mini PCNL, especially 1.5 centimeter and above. So I'm doing a lot of supine mini PCNL, and in those cases, I can do endoscopic combined approach as well. But 2 centimeter stones in the renal pelvis, in the upper pole, And the other criteria for me is multiple stones, right? Where even with a PCNL, a single tract, you can't clear everything anyway. And then you want to do multi-tract. And of course, there are many surgeons in India who are very skilled with multi-tract procedure, but multi-tract is extra morbidity. And so multiple stones is a criteria for me to do RIRS. But in general, 2 centimeter and under, I will do ureteroscopy. Anything above 2 centimeter, I will try and do percutaneous procedure if possible. But I have to say, in the modern day, many of our patients are on anticoagulant, antiplatelet therapy, and they're increasingly getting ureteroscopy. So these are the cases. And I have many cases of stags that I've done 2-stage procedures and got complete clearance with RIRS.
Generally, doing under general anesthesia RIRS is comfortable. As you said, you are a duster. I do all cases under general anesthesia. Your comment on that, especially if you are planning for daycare.
Yeah, so general anesthesia, but in terms of the intubation, the difference between an LMA and an endotracheal intubation, is where the patient's ventilation can be erratic, and especially heavy patients, and it does make the movements in the kidney more problematic and targeting. So that's the discussion I have with anesthesia. But I do have some patients that I do under spinal, and those are the ones with COPD or have other complexities. And I do spinal RIRS, and I think it's absolutely feasible and fine. I will sometimes just tell the patient, if you're going to cough or sneeze, just let me know, because we're operating and we don't want that sudden movement. But general is what we tend to do. But in the patients with severe respiratory disease, spinal.
I have seen your paper on the low temperature solution for irrigation. Do you have any concern about hypothermia to the patient?
And that's work done by my partner, Will Roberts. And I think it's that is an area of further exploration. We still need to do more clinical work to see if there's, but so far from what we saw in the animal model, no, there wasn't any term. It was localized.
And in fact, I wanted to ask, most of the lasers work photothermal. If you make the temperature of the solution low, do the air bubbles in any form lesser and efficiency will be less?
No, I don't think the temperature of the fluid will affect that aspect. The mechanism of the laser is based on the wavelength, and then that heating phenomenon is occurring, and that will happen right at contact. And so remember that in a few millimeters away, all of that energy is dissipated and gone. And that's one of the major differences between holmium and thulium, which is the wavelength differences are going to cause differences in fragmentation, especially around contact and heat dissipation.
You are favoring dust. At the end, you mentioned that the fragments are formed anyway and you have to go to popcorn. If I say that if you are in a localized calyx, dusting takes high technical skill, lot of movements at the wrist, lot of holding the scope in a firm manner. Instead of that, if you voluntarily make fragments with high energy as quickly as possible, so that they will come to a stage of floating, quickly go to popcorn where the technical skill is less and ultimate endpoint is the same powder. Do you agree for this or not?
I have colleagues who do that strategy is that the strategy that you use?
Actually, thulium fiber laser, after buying, I was a previously standard dust till the last piece. I want to dust. That is my aim, so that stone free rate is very less. But as soon as I have taken the thulium fiber laser and my stone workload increased, when my time is a factor, I slightly am getting deviated towards the popcorn with high frequency laser. You have 100 watts with holmium, even Moses also, so that we can have same discussion on.
Yeah, and so I think that is there's definitely a strategy that you could do. I've seen people do that strategy. There's a very interesting paper that just came from the Korean group where they did 2 joules and 50 hertz, 100 watts of energy,
Yeah.
2 joules and 50 hertz. I mean, they were using, a 100-watt system, and that's a lot of heat, That's a lot of, but they did an access sheath in every single patient. They used high flow irrigation, just like we do. And they followed up every single patient in an 80 patient series with CT scan and renography to look for UPJ obstruction, for injuries and for problems. And it was, there was nothing of any concern, as you would expect from a normal series of 80 patients. So, and that strategy, had good stone-free rates. So I do think, I will see in the future, but I do think in the future that all of these methods will evolve. My methods for treating the urethral stone has evolved. I do for the urethral stone, I'm rarely now doing fragmentation and retrieval. I am trying to primarily dust them actually and evacuate them directly out of the ureter with a Venturi suction effect. And so I'm rarely using baskets in the ureter. So it's an exciting time. I think the techniques keep evolving.
The only factor which I have noticed in last 2.5 years with thulium fiber laser high frequencies, sudden torrential bleeding in 2 cases, which have been reported by Oliver Traxler sir also in the last month when we had meet. He mentioned that no reason found, probably high temperature submucosal vessel rupture leading to the bleeding. That is a concern, as you mentioned. In your papers also you have spoken a lot about the temperature and irrigation. If the irrigation is not good, it may be harmful to the kidney also.
Yeah, and I think in the US, the environment in the US is here, more of us use higher flow to irrigation. So temperatures may not be an issue, but in Europe and other areas, the philosophy has been gravity drainage, low flow. And I think that's going to be an issue. I've also had one case of bleeding with thulium as well, suddenly, boom, and I had to just stop the case. And so, but I think one of the issues with thulium is it's a true contact laser. You really have to, you agree, you really have to touch the stone. You really have to touch it. And those maneuvers, I find sometimes, especially for difficult stones that are lodged in the kidney and you're trying to touch it, if you accidentally touch the mucosa in that scenario, both. So there is the difference. So I think there are some good things about thulium, but there are some limitations that the surgeons need to be aware
of. In 12/14 sheath, if you use water, does not retain much in the kidney. Sometimes you feel everything collapsing. Sometimes irritating when the laser may touch it. Especially if you are using irrigation not by pump, only by gravity. Water will not retain like in supine PCNL. You may not be able to dust very properly unless you have some amount of the water inside the PCS. A comment on that.
Yeah, so I'll push the sheath further out, not so close to the kidney. That then allows the kidney to distend more. I will increase the flow rates. We have a pressurized system, so we get them to pump up higher flow rates. But you're right. Sometimes an access sheath can be limiting. In that scenario. If you have pre-stented patients, I don't think you need an access sheath. So they're pre-stented. Many of the times, I don't use sheaths.
An important question. Most of the times, you try to relocate to the upper calyx. You also mentioned interpolar calyx. I feel upper calyx is a compound calyx. Even if to push, it is slightly higher. You may not be able to push. Once you push, you are not sure whether it will be end on. It may be onto the posterior. Then it is very, very difficult. I feel middle calyx is very good. Or else if you push the scope, wherever it goes, that is the ideal calyx. What is the comment?
You're absolutely right. The two most difficult areas in RIRS are lower pole and medial, right? Upper pole, medial, posterior.
Very difficult.
And they are difficult, especially for the angles that you give. So that's why I say inter or upper, and you have to judge the system. And not all of the upper poles are like that.
Yes.
Typically, I in the beginning, I used to say upper because I want that nice passage, I want that nice exit route for all the fragments, but I definitely agree. You have to choose one of the ones that is the most forgiving for you.
Yeah. When you dust on the surface of the stone, the ablation rate versus when you do at the edge of the stone by microchipping, same. But when you do at the edge of the stone with water interface, it appears very faster. Normally we try to keep the surface area till the last minute so that the stone won't obble. But if you do at the edge, it appearing it is very fast ablation. So surface stone can break. At the same time, you don't appreciate the fragments whether it is happening or not, especially if you don't touch. So a comment on that. Should we
Yeah,
come
and
from
that's
periphery to center or surface reduction of the volume?
I think you have to do it both. And this is
Yeah.
when I train the residents, I say, okay, enough of here. Let's go to that side right now, because too much surface you lead to fracturing of the stone. But definitely chipping is wonderful, and I love chipping for the
Yeah.
reasons that you described. The only problem is you can't always chip because you've got urothelium sometimes in your way. So it's a balance of not making bleeding and attacking the stone. But the key is to keep moving, and just keep actively laser lithotripsy, and not stop start, but just keep interrogating the stone.
You have mentioned in your paper that continuous popcorn may cause raise of temperature irrespective of the laser. Stop it and do it, stop it and do it. Two reasons. One is vision may not be good. Second thing is that temperature can be reduced. It's true. Especially in thulium fiber laser, we don't see if you go more than 200 hertz, vision will totally disappear. You have to stop every 30 seconds. Is it the
Yes.
same with 100 watts laser homium?
Yeah. I think, the pop dusting settings that we use, you do get a lot of visual disturbance. You do have to stop. You have to make sure your fiber tip is not too close to the calyceal edge. And so stop, start for those reasons, for safety. And I do think the vision, whether it's with thulium or advanced holmium systems, is going to be an increasing problem. You like dusting, I like dusting, but we're going to have to tackle this issue with vision. And that's where I think we're going to see some exciting developments in the future.
Last couple of questions. Previously, the concept of autologous blood injection into the inferior calyx is there. Most of the times, if you do in situ inferior calyx, however small the stone, even if it 1 mm, chances of moving it slightly lesser than in upper calyx and middle. A lot of dust accumulates which is difficult to wash from the lower calyx. So is it not a good idea to pack it up lower calyx and do somewhere else so that your stone free rate may be better?
Yeah, and I think using a basket to move the stones out of the lower pole is absolutely feasible. I don't have data, and this is something that we need to collect on. But in my experience, the amount of time for me to do that and the results that I'm seeing with the high power systems for forgiving lower pole stones, you can get complete stone clearance. I don't think you need to translocate every single stone.
You have done a lot of research. I have so much interest in two things which is very difficult to imagine. How do you measure intrarenal pressure without puncturing the kidney during RIRS? One question. Number two question, how in human beings can you measure the temperature inside the PCS? You have done too much baseline research. Can you give some guideline on this temperature and pressure monitoring without making a puncture in the kidney?
There are guide wires that are available, cardiac-based guide wires that you can feed into the working channel of ureteroscopes to measure pressure, if you would like, even right now, but they're quite expensive. In the laboratory, we have a fine pressure sensing guide wire that we can feed into the models and into the kidney. Others have used percutaneous needles to measure temperature. And say likewise with temperature, you can feed a fine probe into the working channel. Coming forward, the next version of the LithoView from Boston Scientific will have a pressure sensing system. So I think we're going to learn a lot about what pressures, and I think the very limited data that we have from Dr. Clayman's group and Dr. Traxer's group on what are the pressures in the kidney, I think the pressures in the kidney are much higher than we imagine. And I think once we start measuring it, once the new scopes come out, we're going to start seeing a different world. And I think that's going to start affecting how we do things.
So in ureteric stones, high power and high wattage lasers usage, what is the tips you wanted to give? A lot of discussion on ureteric strictures, temperature raise.
Yeah, I just want to say that I don't use high power in the ureter. I use less than 10 watts of energy. If I do dusting, it's a very low frequency. It's 30 hertz. My go-to setting is 0.3 and 30, or I'll do a fragmentation technique. I'm very conscious about the energy use in a confined space of the ureter with the flow rate parameters. So low power settings, less than 10 watts.
So definitely last question. I have seen last 3 years phenomenal amount of research on basic things have been done. What the message you wanted to give the junior urologists from India who have less exposure in writing papers with a lot of volumes? How your team works? What is your team constitutes? How you manage your time to enter the data, analyze the data, follow up the patient? It is a tedious job. A comment on that so that we can conclude the session.
Yes, I'd say that I'm very fortunate to work with good partners and colleagues here at the University of Michigan. You know, my partner, Will Roberts, has got a strong track record in basic science research and translational laboratory work. So I've been fortunate to work with him to explore this area in terms of some questions that we see in the clinical arena that we then translate to the lab. The fellows, you know, what I would say for anyone in India, you know, who's doing these surgeries, there are so many things that we don't know. You just made a statement now about the techniques between, do you do the popcorning this way or do you do it this way? We don't have any data on this. So there you have a study. There you go. Right now, somebody in India should be able to do a study where they compare that technique to this technique in 50 patients each and look at some outcomes. And I think you can start small. You know, one of my mentors in Edinburgh, Alan McNeil, you know, only did a randomized trial in 80 patients, but yet changed the field of urology. And that's to do with alpha blockers for urinary retention. Do you give an alpha blocker in patients in urinary retention? So it's the most simplest, most impactful things happen in clinical practice when we're asking. So what I would say is just ask the simple questions like, why are we seeing this? Why does that happen? Is this better than that? And that is your baseline, and that is how you start.
Great. Thank you very much. And we will definitely like to see your program in September, DUST program. I will be very happy if you are using Facebook, join the Pure Urology. In fact, even if you don't, you please send me the message and the link so that a lot of audience, 6,000 across the world, including Europeans, Asians, lot of people have joined. So we will definitely love to watch. Last year, I think in Chicago it is done. Same program organized by you. I have seen that. So
Yes,
hopefully we will see the entire program related to stone in the upcoming DUST program. Thank you very much, Professor Ghani, for being with us. Amazing talk and very crisp. And I'm really surprised to see your papers. All are answering very, very common questions. I've gone through all the abstract of 170 papers. Last 3 years, you have done extraordinary work on the basic endourology stone disease. Thank you very much being with us today.
Thank you. Thank you, Dr. Mohan. Great pleasure.
Thank you very much. More than 250 audience have watched live, and the same link will be used forever to see the program, those who have missed in Pure Urology, so that you can update your knowledge. Thank you very much.